So good afternoon. I think everybody is happy with lunch. And for those who are enough patience to go on with works, we are beginning this session. So the first speaker we are going to call is Dr. Rui Henrique, who is going to speak us about prostate biopsy.
So, good afternoon to everyone. I hope you had enjoyed a good lunch. It was superb for sure. And I just would like to thank Dr. Caleda Silva and also to the members of the stand for inviting me to be here. So my main job today is to talk to you about prostate biopsy and try a best effort to tell you something that you already don't know. So let's do that. So the menu of my presentation is this. I'm going to speak a little bit about the current role of prostate biopsy. How do we make the diagnostic approach? I will not go very much into detail because we don't want competition at this level. Then we'll talk about evaluation of prognosis, about reporting, and some prospects and challenges. So why do we have a 15-minute talk about prostate biopsy? Well, obviously someone wanted me to be here to speak, so that's important for that purpose. But there is something that is unique to prostate biopsy. And this is the fact that it is not guided by a discrete lesion that we see in terms of imagology of clinics nowadays. This will change for sure when we start using routinely MRI for guiding our biopsies. But for our practical purposes today, the fact is that we need a systematic sampling of the prostate to get a biopsy and then to interpret it. And so this means that prostate biopsy, more than other biopsies for tumor, is more prone to misinterpretation and misclassification. And so everything that comes then about diagnosis, prognosis, prediction has all to do with this. So this is what we could say the standard of our days in terms of approach. And so the pathologist has these small fragments or larger fragments of tissue to look at. And what is asked from us is from these minute fragments to make a statement about is there cancer or not, and if it is cancer, how bad it is. So what does the pathologist has to do with this? First, we have to make sure that the tissue that comes to us is adequately processed and that we obtain the most information out of this tissue. Then we have the task to perform the diagnosis and then to provide you information that is obviously critical to decide the therapeutic of the patient. But more important than this is that we have to do this in such a way that this information is intelligibly communicated to you so that our report is simple, is direct, and makes no doubts in your heads about what is there in terms of tumor. So let me just go some useful guidelines. Some of those are better for pathologists, others are also for urologists. One of them is the fixation liquid that we use. Most of us like to use neutral buffered formalin. This may change in the future. As you might know, there is an European initiative to ban formalin from its use and commerce. So this is a quite important issue for us as pathologists. And also very importantly, to individualize the fragments as much as possible. As active surveillance becomes an option in terms of treatment, or in terms of follow-up of the patient, then to make individualization of the fragments and have fragments that are not fragmented is absolutely critical for the pathologist to convey an important and very relevant information. Then, for us as pathologists, we have to make some adjustments in terms of what is our practice. For instance, we should not embed more than 1 or 2 tissue cores per block. I know that this might be the practice in several places, but it is not just a personal opinion. This is mostly opinion from very important uropathologists, and the reason is there. So when we do this, when we put more than one fragment, we have a high likelihood of having these two fragments in different planes. And this means that when I get the sections, I will not have a full observation of the fragments. At the same time, I will lose some of the information, and I could not obtain it at the same time. So this is wasting material, and it is, in some cases, might be prone to interpretation wrongly what are the grade or the diagnosis of this patient. There are many morphological criteria for prostate cancer, and it's not my role to be here and telling them for you in particular. When I look at a prostate biopsy, always comes to my mind what I learned more than 20 years ago with Professor Carlos Lopes, that is standing there, and it was my chief and head of department. And his first lesson on prostate pathology is that cancer is mostly a problem of architectural disarray and cytological atypia. And for me, those are really the two main issues, the two main criteria that I use today with my residents as well when I start teaching about prostate biopsy. Well, we know that there are some specific features that might be very specific for cancer, but not in all conditions they are present, and some of them are sometimes difficult to interpret. So when we have images like this, it might be very easy to make the diagnosis, but in prostate biopsy, this does not occur in many ways. And the main problem in this setting is that we have a lot of differential diagnoses and pitfalls when we go for prostate biopsy and also in prostatectomy, but the main issue is obviously in terms of prostate biopsy. Obviously, in prostate biopsy, a typical adenomatous hyperplasia or even sclerosing adenosis are not the main problem because these are mostly lesions of the periuretral area. But as we make more and more saturation biopsies, then some of these lesions will come up in our tissue. So when we have doubts, what we can do is to make use of immunohistochemistry. And so there are some markers that we can use in practice to make differential diagnosis between prostate cancer and mimickers of prostate cancer. What I think is important from this setting is that no marker is absolutely specific and definitive for prostate cancer diagnosis or its exclusion. And this means that most pathologists will rely on his morphological assessment or her morphological assessment and then use these markers to stand more firmly their diagnosis and use it in doubtful cases. So this is not something that we use as a routine in all biopsies. This is something that we should only use in cases that raise suspicions of prostate cancer and in which morphology is not enough. But morphology is still the basis. And as morphology is the base for diagnosis, is also the basis for classification. And I know that the newest classification is now almost 1.5 years old, but there are some issues that I would like to speak about very briefly about this new classification. And one of them is obviously that all the cases that we knew and all the subtypes that we knew from the past, they are there. But there are some new additions. One of them is intraductal carcinoma, and I think this is an important new addition for our lexicon in prostate cancer. First, because it is a lesion that is relatively rare, but we can find either isolated or in concomitance with prostate adenocarcinoma. And what is important in this lesion is that it is typically associated with high-grade and advanced stage adenocarcinoma. So every time a pathologist in his biopsy makes a statement or a report about this type of lesion, we should know that this means an aggressive cancer that is probably high stage and very aggressive disease, even in prostatectomy. One word very important in terms of caution. These lesions should not be graded. And I will show you the image why it is important to make this statement. And when present, and because not all people is always in their mind with this lesion, we should obviously state that when we see it, that there is an association with aggressive disease. Okay, so why should we not grade it? It is important to recognize this. If I don't recognize this as intraductal carcinoma, this would mean that this is a Gleason 5 tumor, Gleason grade 5 tumor, because we see here comedonecrosis. But if it is intraductal carcinoma, this is not Gleason grade 5 carcinoma. Okay? It is just intraductal carcinoma, and this may make a difference in terms of the decisions for therapeutics in this patient. Okay? Another addition, which is not as relevant in my point of view, is the fact that there are two new variants of acinar adenocarcinoma, which is the most common type of adenocarcinoma in the prostate. These are the microcystic and the pleomorphic. These are not very common subtypes. The main problem here is the differential diagnosis with benign lesions, and here is the fact that this is a very, very rare lesion, but has a very bad prognosis. And then we also have a new addition in terms of the neuroendocrine tumors. This is the newest addition to this type of tumors, the large cell neuroendocrine carcinoma, which is quite rare, but it is now recognized for the first time. As we could expect from what we know from the other organs, this is a very aggressive disease with a very poor prognosis. So after making the diagnosis, what do you expect from the pathologist is to provide you information about prognosis. And that's what we do when we talk about grade and tumor extent, and these are the two main issues that I will, in this sequence, to talk to you about. When we do grading, we have a very important objective, and this is to predict clinical outcome. But the word is to predict. So we are not wizards, we don't know the future, we cannot define it, but we can try to give you information about its likelihood. And so when we do this in the biopsy, we want to tell you what could be the stage of the tumor in the radical prostatectomy specimen, so you can decide whether this is or not a very good treatment option. But we should be aware that there are problems and limitations with this approach. We don't have the same eyes, we don't have the same brain, we don't have the same teachers, we don't read the same books, and obviously we don't see the same slides. Some of us see one slide, one section. Sometimes when we get the same case, we have other sections from the same case, and it is different. So you should expect some variability in terms of what is the interpretation of the pathologist, and obviously we should expect that if you are more experienced or dedicated to uropathology, that this grading should be more homogeneous in terms of what is your approach. But there are no miracles. And I don't know anyone that is always and absolutely 100% right. Okay? What we need also to know is that our system has changed. And these days, when you speak about Gleason grade, which is the basic grading system, we are actually speaking about 3 systems, which are of different age. We know what is the one that we should use today, but sometimes it is not very clear what system are people grading when they do their report. And I think that is very important. So if you work with a pathologist, please ask him what system, what Gleason grading system is he using, and I will show it just in a moment. What were the major changes since 2004-2005 when this was reviewed? First, we had some question about cribriform glands. Were they grade 3 or grade 4? No, they are grade 4, and that's period. So it's not a discussion anymore. We know that glomeruloid glands are also grade 4. When we see mucinous adenocarcinoma, we make a kind of subtraction in our brain. We take out the mucus and we grade the tumor that is left there. And we know that grade 4 also encompasses poorly formed glands. So this is the base of our work, and another addition of the WHO classification is that we should estimate the percentage of grade 4 when we have a Gleason score cancer. This is not easy. This is not, I think, reproducible, or it was not tested as reproducible, and more important than that, the book does not state how we should do it. So when we make this and we do it for routine in our department, we should always bear in mind that this is an approximation. So obviously, if we see something like 60% or 70% of grade 4, this means that that cancer is probably more aggressive than when we see a cancer that has 4% or 5% or 10% of grade 4. So this is a kind of a spectrum, and it is very difficult for us to know these days how much this has impact on patient. Another issue is that whether we should we should estimate the percentage of grade 4 or grade 5. In the WHO, this is not a particular recommendation, but in the College of American Pathologists guidelines, this is a recommendation. And we don't know for sure what is the impact, but this is stated as a recommendation to look in the future for the potential impact of this statement. And this is the view that we can have of the free Gleason grading systems that you may use. So this is not already the original, but the one that we know better. Then we evolved in 2005, and then we have a new one in 2016. And what these lines and these arrows here try to show you is that what happened actually is that we raised our definition of grade 3. That's what happened in practice. So today, a grade 3 must be very different from what in 74 or 77 we called a grade 3. It might be very, very different. So with this, what we want to do is really to discriminate among tumors that might kill a patient and tumors that are not very likely to kill the patient. And that is the reason for this evolution in the Gleason grading system. So you see why it is important for us to know in which Gleason grading system are we talking about. If you are speaking about, for instance, active surveillance, then we should know that what we are grading is here. Because if you are grading here, some cases that would be 3+3 and would be eligible for active surveillance, some of them could be actually 3+4 in the new system. So another addition of this new classification is the grade groups. I disagree with those that think that this is a replacement of Gleason grading. It is not a replacement. I think it's a refinement of Gleason grading, and it's a way of putting Gleason grades inside groups of prognosis. And this is also important in terms of emotion for the patients. Why? When we use the old system, a Gleason score 6, which was the standard, for a patient that knows that Gleason grade goes from 2 to 10, it was in the middle of the disease, so to speak. But when we use this system, that patient knows that he is in the bottom of the disease. So he has the lowest aggressive disease that you can have for prostate cancer. And this is very different in the way that you look at the disease. And importantly, this has been extensively, I would say, validated both in prostatectomy series, radiation treated, and conservatively treated patients in biopsy. So I think that the grade groups are here to stay, and we should adapt to this existence. There are some issues about grading that we should know. In biopsy, obviously, these scores do not exist anymore, and I don't think it's necessary here to tell you the reasons for it. If you have low-grade patterns, less than 5%, you should ignore them. They will not make any difference for that patient. And you should always report high-grade patterns. They are important, and we know that if we use this system, we will have a better correlation between grade in biopsy and grade in prostatectomy specimen, and that's the purpose. So how should we grade? And this comes again to the problem of the fragments. Okay, if you have very nice separate cores and different fragments, we can do this, which is the recommendation that is made. So we can grade each core independently, and we may provide a global score. It may be relevant, or it may not be relevant. But we have multiple cores in the same container, and particularly if they are fragmented, then we might only report eventually a global score. We can make an effort to grade each core, but this might be erroneous, this might be misleading, and it is actually not very correct. So with this picture, I just want to show you how we grade these days. So eventually, in the past, this could be graded as a 4+3 adenocarcinoma. But actually, this is not. This is presently a 4+5, and this is a grade group 5. Okay? So this is not the complete fragments. It's just for illustration, but to tell you that it is not a matter of what is the second most common. The problem is what is the most aggressive grade.
Please.
Yes. So finally, to go to the tumor extent in biopsy, we should recall that the amount of tumor that we see in biopsy correlates with very important outcomes like pathological stage and biochemical recurrence. And there are a lot of measures of those extent. So what we should do is to be aware that they are not exactly the same. So the minimum is to state how many cores are involved by cancer. Another possibility is to talk about the linear extent in the whole, but be sure that if you use different criteria, we may end up with different approaches and different figures for this. Okay? In this case, you may see, no, this is not important at all. But if you have only one fragment and you have a bit of cancer there and a bit of cancer there, this might be the difference between having 5% tumor or having 10 or 15% of tumor counting the whole specimen. So it is important also for urologists and pathologists to go through this and know what they are doing in terms of reporting. So when we do histological type and grading, we should follow rules that are now quite well defined. And when you go for the tumor extent, there are also a number of possibilities, and I think these should be put together depending on the correlation that we have with the urologists. But this does not mean that everything is solved. There are still many issues in terms of tumor extent that we should investigate in prostate biopsy. Finally, just two or three things that I think that are important for the future. One of them is to know when a negative biopsy is truly negative. Sometimes we speak only about prostate cancer and we forget that most biopsies in community-based setting are actually negative, and we want to portray to the patient if those negativity is really negative. So in this case, I think that we should go for confirmation tests that may allow us, with a high likelihood of negative predictive value, to define whether or not there is prostate cancer. And this can save a lot of biopsies in the future. Another thing is how we can refine the prognostic accuracy. We speak about molecular testing. For prostate cancer, we have a lot of them. Many of them are based on the expression levels of genes involved in cell proliferation, but we can also use them in immunohistochemistry or in situ hybridization. And from these, I think that the most promising and probably the first that will go for practice are P10 and Ki67. And finally, if we want to move forward, and breast cancer was mentioned here for several reasons, probably you should take in consideration the example of breast cancer. So imagine what is speaking about breast cancer today without molecular subtyping or approximation. So I think that we should do a big effort to move towards a molecular classification. The bases are there. I think what we are missing is adequate biomarkers to make it feasible. Thank you.
Thank you, Professor Rui Henrique. Since the time is going out, I'm just going to do one question from the table. What do you think about G6 very extensive? Do you worry with this kind of final pathology, or do you think it's advised to repeat biopsy?
So you are speaking about Gleason score 6 cancer G6 with extensive. Well, I think that the most important issue of the extensive Gleason 6 is that the more extensive cancer that you have in the biopsy, that means a larger cancer also in the prostatectomy specimen and a higher likelihood of upgrading in the prostatectomy specimen. So I think that in those cases, if active surveillance is an issue, mostly for the patient, I think that probably it would be important to have there information that is supplementary, like MRI, or even, if necessary, a more, I would say, expanded sampling of that tumor to be sure that it is actually 3+3 and Gleason score 6 tumor. That's my opinion.
Thank you very much for your nice talk.
Oh, sure. So next up, we have Dr. Bashar Omabasha, who's joining us from New York at Upstate Medical University, and he will actually be giving us 2 lectures today. But take it away on epidemiology and screening.
Okay, thank you very much. Thank you, Dr. De Silva, on the invitation. I've been to many meetings, but I was never treated the way we are being treated in this meeting. Thank you for the hospitality. I have 3 disclosures to make here before we start. First disclosure is I am not this guy. Dr. Haas had an emergency last moment, and he was supposed to give this talk that actually this is his slides, and he asked me to give it last minute. He had an emergency. Not health emergency, he's healthy. I know he has a lot of friends in the audience. It was a professional emergency, and he couldn't make it. So I'm going to give his talk. Hopefully I'll do a good job. The problem is he sent me 50 plus slides. There's no way we can do it in 20 minutes, so I'm going to skip some of them. But I will hopefully keep the spirit of the talk so you know what the message he's trying to pass to you, which is to screen or not to screen. By the way, let me finish my third disclosure. I did not vote for Trump. Just a raise of hand, who agree these days that we should screen? Just raise your hand if you should screen for PSA, prostate cancer. Raise your hand. Okay, not screening, no screening? Okay, so today we're going to talk about screening or not screening and what are the problems with the issue of screening. So the objective of this talk is to review the epidemiology of prostate cancer and then to understand current international screening guidelines, the difference between the guidelines, mostly the European versus the American guidelines, and to understand the clinical data which the guidelines used to make their guidelines, and how the adoption of the guidelines is really changing the epidemiology of prostate cancer because of the adoption. So what is the purpose in 2016 and beyond in treating prostate cancer? What are we trying to accomplish? We're trying to treat prostate cancer that needs to be treated. We would like to cure as many patients as possible. We'd like to prevent or delay development of metastatic and castrate-resistant prostate cancer. We'd like to protect the quality of life of the patient. We'd like to avoid unnecessary treatment of cancers that are not aggressive, i.e. group 1 or Gleason 6 or below, avoid unnecessary biopsies, avoid unnecessary treatment, avoid complications of unnecessary diagnosis and treatment. We would like to avoid, the way we like to avoid unnecessary treatment is by diagnosing the right disease, the high-grade disease, to avoid diagnosing insignificant disease, and to propose the right treatment for the right patients. Not all patients should be treated the same way. And active surveillance of cancer of low biological potential using biomarkers and other issues. I'm going to go through them with you. So prostate cancer is very common. These are, we know that second or third cancer in men over age 50. Prostate cancers, if left untreated, will kill you, deadly. Early detection of with PSA leads to diagnosis of prostate cancer earlier, at earlier stage, and reduce metastasis. And early detection with PSA probably, this is still up for grab, leads to decrease in mortality. So prostate cancer starts in the 20s and 30s, and this is published by the author of those slides, Dr. Haas, who used to live in Detroit in the 80s, and he used to tell us that he had this knife and gun club. Knife and gun club every Friday and Saturday night. It used to be young men, mostly drug dealers, killed and shipped to the morgue, and he used to go to the morgue and take the prostate out and autopsy him. And to our surprise, he found at least 20% of cancers in men in their 20s and 30s. So that's the prostate cancer start at a very early age. Not every one of them become clinical cancers. So the prevalence of prostate cancer is much higher than the clinical cancer that we are seeing. Early detection with PSA may lead to detection of some clinically insignificant cancers because of this fact. And the characterization of early prostate cancer is difficult because only we are seeing the clinical cancers, so we will never know the latent ones. So what happened over the years with the discovery of PSA in the mid-80s, early 90s? We had significant surge in the incidence of prostate cancer cases in the States. And most recently, we have seen some decrease because of the guidelines. There's people doing less PSA screening, so we are discovering less cancers over the last couple of years. And as far as mortality over the years, we did impact mortality significantly. I remember in my training, when I finished my training in the mid-80s, late 80s, most patients were coming to us with metastatic disease, and the mortality was in the 40,000 plus, and we were able to bring it down, as you see, over the years, and this is due to the early detection and screening. Again, I'm going to skip some slides for the sake of time. You all have seen this before, the dramatic increase in the incidence of prostate cancer that happened in the 90s because of the screening, and actually stayed up, as you see here, over the years, and was sustained despite. We did impact the mortality. It dropped down by 40%, also due to early detection and screening. I'm going to skip this as data. So it's a disease of the West. So North America, Australia, Caribbean, and Western Europe has the highest incidence, and it's least in Asia and certain parts of the East in China. Now, dying from prostate cancer, as you see here, was very high in the Northern European countries because they were not treating. Only expectant therapy used to be done. We have a high incidence of black people dying in our country because of the biology of disease, and African Americans is different than white Americans. And it's less in Japan, as you see in Singapore and Hong Kong. So if you take the whole world, this is the incidence and mortality. So you can see how it's so high in the US and Europe and compared to other parts in the country, in the world. So what is the story with the guidelines? The guidelines started in 2009. First thing came out is the AUA guidelines. And this is what the guidelines was saying to us. Well-informed men age 40 and above, life expectancy of 10 years or more, it's okay to screen. The decision of whether to biopsy or no biopsy, it should take into account a lot of factors. I don't know if you guys remember, in that time was a PSA, free PSA came out, PSA velocity came out, the concept, PSA density, age-adjusted PSA, the family history started playing a big role with the Johns Hopkins studies that came out, and of course the ethnic and race. So these should be taken in consideration. That's what the AUA told us in 2013. Just remember that. At the same time, the American Cancer Society came with their recommendations and recommended that informed decision should be done with the doctor and the patient, and starting at age 50 was recommended. As long as you have 10 years of life expectancy, you should do it. If you are African American or you have a first-degree relative, father or brother, then you start at age 45. If men decide to be tested, they should have a PSA with or without DRE. And how often should we repeat screening? It depends on your baseline PSA. If it's less than 2.5 or higher than 2.5, and either every 2 years or every year. And then we have this bombshell came from nowhere after Obama was elected. Part of the healthcare reforms in the states is to try to cut down on cost, and I think that panel that was created by the White House decided to, without having a urologist on the panel, not one single urologist was on the panel, came up with this statement. Healthy men should no longer receive a PSA blood test to screen for prostate cancer because the test does not save lives overall and often leads to more tests and treatment that needlessly cause pain, impotence, and incontinence. Just like this, with no urologist on board. The same, these people, so they said for every, and the reason they came with this is because of these findings. And a lot of these things were published in our literature, actually. For every 1,000 men treated with prostate cancer, 5 died from complication, 10 to 70 experienced complications but survived, and 200 to 300 people developed long-term complications such as impotence and incontinence. It was increased morbidity, complications of biopsy. 68 out of 10,000 biopsies had either sepsis or some of them ICU admissions and some even death. It was psychological damage to the patient, complications of overtreatment, incontinence and ED. So this was the reason for them to recommend no screening anymore. So the main concern was too many of the patients who are diagnosed have clinically insignificant cancer, which do not need to be treated and therefore should not be diagnosed. And that was given grade D. And by the way, D means do not recommend the test completely. That's what D is when they come up with D. So this was 100% no screening based on D. Now, How did they come up with all these recommendations? They looked at a few papers on screening, and the two biggest one was the PCLO study in the States and the European study here, which I think is one of the best long-term studies, is the European study. And if you look at the randomized US study, there was not much difference between screening and control. In the European study, there was some improvement in survival and in metastatic disease. That's the difference between the two studies. They also had some limitations. The European study had no PSA data on the early phases. The US, 43% of patients had it. The PSA compliance was 82%, almost similar. And PSA test in the controls was lacking in the European study. So the European study had fewer flaws than the American study. They had younger men, they had lower PSA cutoff age, 3, and around 15% screening of the controls, and biopsies were done in 86% of the positive PSA patients. This all published. Dr. Fitz Schroeder showed his results. The nice thing about it is if you look at 11 years, 299 prostate cancer death in the screened population versus 462 deaths in the control population. So there was a difference in survival and also a difference in metastatic disease between the two groups. So the PLCO study, which is prostate, lung, colon, and ovarian study, had a flaw due to contamination of the controlled arms. The European study, 20% relative risk reduction. Screening showed to be more beneficial if you are young and healthier and you're being followed for more than 10, 15 years. It reduced metastasis and death. So what do we do now? With 2012, 2013, every AUA meeting, we have discussions and we have fights about this whole thing. So the AUA came up with the second guidelines, and this is 2013. So the first one was 2009, this is 2013. Now they are saying we recommend against PSA screening. This happened a year after the White House task force saying no screening. So the AUA almost went a little bit with the government. Recommended against PSA screening in men under age 40. Does not recommend routine screening in men between age 40 and 54. So the age is up to 54 now. Recommended to start screening. Strongly recommended shared decision making for patients between age 55 and 69 before they proceed with any screening. Should talk to the doctor. A routine interval of 2 years or more preferred over annual screening, and does not recommend any screening for men over age 70, not even if you are African American or even if you have a family history. After age 70 was not recommended. Same year, the AUA guideline in Europe came up with this more favorable. Early detection of prostate cancer reduces prostate cancer-related mortality. Early detection reduces risk of developing advanced prostate cancer, and recommended obtain the baseline study at age 40, not 54, 40 to 45, and interval screening according to baseline. The lower your baseline is, the less you have to screen. The higher your baseline PSA, the more often recommended you screen. Early detection should be offered to men with life expectancy, which is like the American recommendations of 10 years or more, and they recommended the use of multivariate risk prediction tools such as biomarkers. The only update on the European happened in 2016 when they came up with this new statement that do not subject men to PSA testing without counseling on the potential of risk and benefit. That was added to the European guidelines. Summary of the guidelines, basically the AUA and the European guidelines are similar in terms of evidence-based, in terms of reaffirm that early detection saves lives, reaffirm that early detection reduces metastasis and morbidity, and frequency of screening based on PSA, and emphasize the decision-making with the patient. These are the mutually agreed on between European and American guidelines. The difference between the two is the European guidelines based on 10-year survival expectation. The AUA guidelines are age-based with exceptions. Age 40 to 54 are left out of screening in the American guidelines. So what happened in the big picture? Between 1980 and 2000, we treated every prostate cancer walked in our office. Gleason score 6 or 5 were treated, radical prostatectomy was done, and between 2010, with all these guidelines, we are now looking at diagnosing only significant cancer, high grade, 6 and 7 and higher, and active surveillance came to play now. Almost 1/3 of my patients are on active surveillance. Some people have even higher, and we are using biomarkers big time to help make a decision with the active surveillance group.
If you please, take it over.
Very good. So these are where we are standing right now, the guidelines. There's 2 of them are against European, the ESMO and the USPF was against it. It was reduced in the AUA guidelines, and then there's selective targeting in the European and the American Cancer Society and the Japanese societies guidelines. So what is the short-term impact on the new criteria for screening? The referral to urologists are dropping dramatically from 25-50% decrease for high PSAs. We don't see as many as patients being referred from our primary care colleagues. PSA tests performed are much less than before, and the biopsies are done is dropped by 40%. This is all numbers in the US. And prostate cancer diagnosis now we have 36% less low-grade diagnosed and 43% less high-grade diagnosed. So what's going to happen to mortality? We don't know yet. It's too early to decide. So the screening summary. There are potential benefits. Reduction in morbidity, 20-40% prostate cancer-specific survival benefit. There's more likely to benefit younger people, healthier, who are screened at early age. There are potential harms with the false positive biopsies, and detection of unnecessary low-grade cancer is a problem. A screening decision must be balanced between risk and benefit and potential harm to the patients, and patients should be involved in decision making. So the people at the White House, I remember, who Obama appointed, now Obama is gone. They are changing their mind a little bit. So this is the new 2017 draft. They are now recommending a little bit different recommendations coming because they looked at mature data from a couple studies. And now they are recommending screening between age 55 and 69. And that is now grade C, up from D. And they're still recommending against people at age 70, even if they are African Americans or family history of prostate cancer. So that's where we stand right now. And the question is still, should we screen or should we not screen? Thank you for your attention.
I think that we must move because time is over. And now I ask Dr. Brian Smiles that will he'll have his talk about stromogenic carcinoma of prostate.
While Dr. Miles is making his way up to the stage, I would like to pose a question to our audience. Those of you who are men in the audience, who are over 50, who are basically patients yourselves when you see your primary care doctors, raise your hand if you've gotten a PSA screening. Thank you.
Derek, you've never had a PSA? How about a rectal? Okay.
Less than past 50 years.
What did I do here? There we go. Very good. Good afternoon. I'm Brian Miles, and I'm from Houston, Texas. And my wife and my first time to Portugal, and it has been wonderful so far. I can't thank Fernando Martins and Dr. De Silva for inviting us. It's been a pleasure, and I look forward to learning more about Portugal. Okay, so I'm going to talk about a pathologic component of carcinoma of the prostate. I assure the many pathologists in the room that let's see, how does this work? That I am associated with a very good friend and excellent urologic pathologist, Gustavo Ayala, up the street at University of Texas. We've been working together for many years. Texas Medical Center is in the foreground here. It no longer looks quite like this. All these parking lots that you see are now buildings that are at least 15 stories tall, and some are 30. Over 120,000 men and women work in the medical center every day. It's large. Traffic is horrible. To digress just a brief bit about screening, these issues are going to continue to visit us. The population in the world is aging. As you can see, in England, Belgium, Japan, there's going to be more and more people over the age of 60. If we look at the United States, for instance, at the year 2050, there will be more men and women over the age of 85 than there were over the age of 65 when our Medicare system came into play. And of course, you recognize that seems to be an important age group for prostate cancer incidence and diagnosis. In the 90s, after PSA came out, we at Baylor did lots and lots of studies about different ways to prognosticate. How can we tell how well a patient's going to do? We looked at progression-free probability based on Gleason score in the biopsy, Gleason score in the surgical specimens, the radical prostatectomy specimen, tumor volume, extent of disease such as seminal vesicle invasion or lymph node involvement. We developed preoperative nomograms, we developed postoperative nomograms, and many nomograms have followed, and they are continuing to be refined now that we have entered the kind of new age of biomarkers, proteomics, genomics, and gene profiling. Early on we asked, why bother? Don't we know enough about prostate cancer? Well, biomarkers, I think, are important to help us refine our understanding of the disease. As you look at these 4 common cancers, breast, ovary, corpus uterus, and prostate, you can see that prostate and breast to some degree never stop progressing, and death from prostate cancer can continue, as you can see, out to 20 years. It's a disease that we need to continue to follow. Biomarkers. We read a lot about those. In fact, if you Google it, a year and a half ago, there were over 286,000 manuscripts on biomarkers. I looked at it just the other day, and it's over 300,000 now. If we look at prostate biomarkers, substantial number. A year and a half ago, over 11,000, now over 12,000. If we look at genetic testing products available, at least according to the compliance or the Director of Regulatory Sciences at Bristol Myers Squibb, there are currently 69,000 testing products available. 10 new products enter the market every day. In urology, these are right now the standard products that are available. I use some of these. I think many in the audience probably do also. There's 2 at the bottom I have never used. It's hard to find data on them. They seem to be able to tell you everything about prostate cancer, also about your mother and father and whether or not you're likely to get a traffic ticket in the next year. And as you can see, they're remarkably expensive. All of these are very expensive, which is somewhat of a concern. Back after World War II, there was discussion about the military-industrial complex. Some concerns on my part, at least, and others, that we're entering an era also of the medical-industrial complex. It's just so much going on, and there's so much money involved, it raises some concerns. So does all of this mean as we've been discussing pathologically here, that the old Gleason scoring and grading system has no role to play? I would think it does, and I hope to show you with the stromogenic component that I will be discussing that there's an even more important role for it. A bland Gleason 3+3 should go on active surveillance. I think we all agree with that. But are all 3+3s bland? Especially considering if you look at prostate cancer-specific death, the 8s, 9s, and 10s we expect. But the biggest part of the pie is Gleason 7, and not an inconsequential number in Gleason 6s. Things change over time. So we'll talk about the stroma, which we think in risk prediction may be helpful in risk prediction. The genesis of reactive stroma Cancer starts. We start losing the basal cells, the basement membrane changes, the glands start behaving a little funny as far as architecture goes. But there's not always a component of stromogenic cancers, such as you see here. In many cancers, the stroma really synergistically works with the cancer to help it grow faster, to help it progress faster, to help it metastasize. So the tumor microenvironment we're trying to point out really does have a role to play, even in prostate cancer, for how cancers behave. In a normal stroma, a modest cancer may behave in a well-differentiated fashion. It certainly may behave moderately. However, in an environment where there's a stromogenic component, it can behave very aggressively, grow fast, and spread fast. So I will, as a clinician, digress a bit again and talk about normal architecture. The bundles, the muscle fibers on the left here are normal. The blue fibers on the right are quite abnormal. So we'll look at that a little more closely. Again, this is a 3+3 normal muscle fibers. They look like a muscle. They look like a cross-section of a muscle bundle. If we look more closely, you can see that the nuclei are round in form, and there's a cytoplasm around the nucleus. These are normal fibers, normal nuclei. If we look at this one, you can see that these fibers are rather spindly. They lack a nice round nucleus, little cytoplasm in the nucleus. This is a higher or a lower power view of that, and you can see the difference in these muscle fibers. And you can also see that they're starting to, as you can imagine, elongate the glands, trying to pull them into a straighter, less round, less normal glandular look. And then they can progress to this, which is a horrible stromogenic component, a very bad-looking cancer. So Dr. Ayala first looked at this with colleagues and found basically defined 4 different grades: a reactive stroma grade 0, 1, 2, 3, and 4. And this is primarily based on how much stroma is there. They're all the same abnormal stroma, it's just how much is there. So reactive grade 0 is a very low amount of stroma. And I will point out that these are invariably poorly differentiated cancers, 8, 9s, and 10s. There's very little stroma there. They don't need it. They're already behaving in a bad fashion. Grade 1, 5 to 15% reactive stroma. Grade 2, 15 to 50%. And grade 3 is greater than 50% reactive stroma. Oops, sorry. Initially looked at 200 different histologic or biologic markers. These were reduced to about 25 that were significant in the univariate analysis, but only 4 in a multivariable analysis. As you can see, 2 of these include perineural invasion diameter, which is another talk I love to give because it is often not used, as it might be, by urologists, but also stromogenic or stroma component quantification, as you can see here, a predictor of death in these patients. In prostate cancer, whole mount specimens, there are multiple reactive stroma grade patterns. Okay? You can see many different, but what we look for is the percentage of stroma, which can be found and easily identified in the prostate. And it allows you to give an overall percentage. You can see here in the Gleason subset, when we initially did this, the difference between stroma grade 3 and 1 and 2 was substantial as far as progression of disease and, frankly, as far as mortality from disease went. Initially, if you look at the groupings, you can see 0 to 5 all the way down to 85 to 100%. Significant differences in these curves based on the amount of stroma, abnormal stromal component. And we did settle on 50%, not 40% as in the prior slide. But again, you can see between groupings 1 or 2 and group 3, substantial separation of the curves just by the presence of abnormal stroma. How does it work in biopsies? Well, actually, it works quite well also. If we look overall, and you can see the separation of the curves based on the amount of stroma present. And again, you would expect 0 to be here because these are the more aggressive cancers. These are the 8s, 9s, and 10s. And if we've focused that on Gleason 7s, again, you can see an even more dramatic separation with the presence of grade 3 versus 1 or 2. So is cancer determined by itself, or is the host to determine it? Well, I think both, of course, are true. The lethal phenotypes are going to be the 8s, 9s, and 10s, but also those with a strong stromogenic component also behave in a fashion very similar to the poorly differentiated cancers. This is studied by the Canary Group. If you look, it's a number of well-respected institutions: Cleveland Clinic, MD Anderson, UCSF, Hutchinson, Stanford, University of Washington. And this study, as you can see, shows down here that a stromal response is currently not evaluated in routine histologic assessment. Its unrecognized presence leads to a significant underestimate of risk in this aggressive set of prostate cancers, and they strongly support incorporating reactive stroma into the final routine assessment. This is a graph we have from the Hopkins data. Johns Hopkins took their patients and looked at reactive stroma grading. And you can see for Gleason 6 or 7, the more stroma, reactive stroma, the worse the prognosis for the patient. This looks a little odd because it seems that the more stroma you have, the better off these patients are with Gleason 8 or higher. And this is kind of a misconception in a way. What's happening here is for the aggressive cancers, 8, 9s, and 10s, what we found is you need at least 85% of the stroma to be reactive stroma. And with the 8, 9s, and 10s, there's very little stroma, honestly. With Gleason 6, 3 plus 3, all you need is about 30% reactive stroma to have a poor prognostic, be a poor prognostic indicator. For Gleason 7, 50%. Again, a study done out of Norway looking at the prognostic value of reactive stroma. They found that it was, in a multivariable analysis, that patients died more quickly and had a higher risk of death when they had the presence of reactive stroma grade 3 at the levels we talked about. And as you saw on the side in the red, Angelo DiMarzo wrote an editorial comment about this article back in 2015 when it came out. It was a Norway group. And I think you can read that. But he says, certainly additional follow-up studies are needed. Nevertheless, it is interesting to ponder in this, whether in this era of whole genome sequencing and increased complexity of technology, such a simple H&E-based measure could end up becoming a widely used new standard. So I hope I've shown you, at least at some level, what appears to be an indolent cancer may in fact be a lethal phenotype, depending on the presence or absence of reactive stroma grade 3. So in conclusion, reactive stroma is an important microenvironmental factor in prostate cancer growth and progression. Reactive stroma grade 3 is an independent predictor of biochemical recurrence and in Gleason 3 plus 3 death. Quantification may be, I won't talk about that. Quantification may be very valuable in helping select men for watchful waiting. I certainly use it for that. But of course, more studies need to be done, and we hope to share those with you in the future. Thank you for your attention.
Professor Bryan, thank you very much for your talk. May I make a question for you? Besides the reactive stroma, there are some papers that goes for looking special genes inside the stroma among prostate cancer G6 score. And these genes has a prognostic effect. What can you tell us about it?
I'm not sure the gene you're talking about, so I can't tell you much about it, but
There are at least two papers with two different genes that has been looked in prostate stroma,
yes.
in G6 prostate stroma, that can have prognostic value about the recurrence of G6.
Right, but of course, we welcome all of these different tests to help us refine nomograms, to refine our prognostication for patients. And what I'm hoping to introduce here is the concept that the stroma alone can also be used in that method.
Okay, thank you very much. Any question from the audience? Dr. Pedro, please.
Well, the biggest problem is the problem of subjectivity on analysis. You know, you talked about quantification. Because it's very difficult for a normal pathologist to be in agreement with the next colleague about how many, if the tumor is stromogenic, and how much stromogenic is the tumor. So I pick up what Dr. Pino was saying because I think it's going to be published, or has been just published, a study from guys from Vancouver that shows that the genomic arrays derived from the stromal genes can have implications in terms of deciding the cases in Gleason 7 who are going to have metastatic lethal cancer and not. So these are probably an avenue for the future, but currently, you know, using this methodology is very difficult because we don't have a easy way to standardize the assessment of the stroma.
Yeah, understood. I would, 15 minutes is a short period of time. There's a whole section of this talk on deconvolution microscopy that can be used to standardize looking at this tissue. Instead of looking at the red, green, blue spectrum, you're looking at the whole spectrum, and it can, I think, obviate this question of having pathologists find a way to agree, because you're right, as it was pointed out earlier in one of the talks, it seems the best you're going to do is a 60% concordance rate among pathologists for Gleason score, plus or minus 1 point, shall we say. Deconvolution microscopy is a way of looking at a whole, and tissue segmentation, a way of looking at a whole specimen, and in a standardized way that doesn't take the pathologist out of it, but it certainly aids the pathologist in coming to a more standardized approach to looking at stromogenic cancers.
Can I make a comment, Pina?
Yeah, so, Professor Edson.
Yeah, a couple comments. First, I have always admired Dr. Ayala and Tom Wheeler from your institution. Dr. Ayala, for some of you who don't know, was one of the first people who pointed out that the so-called prostatic capsule is not really not an anatomical capsule. No.
It's a different IR.
Is it? But it's the same name, probably his son. The second point that I want to make is, at least in bladder cancer, and this is from David Grignon at our institution, and Reverie, who is now in Paris, that showed that fibroblast growth factor in bladder cancer, it's very important in prognostic, both from the stroma and from the tumor itself. So the stroma cannot be ignored. And if I may suggest to my friend Pedro, what we need in the stromal classification, beside the subjectivity, is what Dr. Gleason did for prostate cancer after 1985.
Thank you for that comment.
Right?
Thank you very much.
I think
Thank
Dr.
you.
Miles has taken all the questions he's going to take this afternoon, and we're moving on again to Dr. Basharo Mabasha, who's going to enlighten us about fusion biopsies and MRIs.
Okay, thank you. This is great. Most of you are still awake, which is amazing after that lunch. So I'm going to talk about this. How many of you has access to ultrasound fusion biopsies in your office or hospital? How many of you has access? Okay, good number. Okay. So we are a 29-man group in practice, and we have our own UroNav system in the office, so we do tons of those biopsies, becoming almost standard of care. I have no disclosures. So around 30 million tests for PSA is done in the US every year. 1.5 million of them come back abnormal, translate into 1 million biopsy, patients go through biopsies, and we are picking up only 250,000. So we know there is missing cancers there. Some of them are not being diagnosed. Negative biopsy is too high. Imperfection of the existing system, the way we've been doing it for 25 years with the ultrasound, we do it blindly, basically. We have sampling errors. We try to get around the sampling error by doing more biopsies. The only one who was happy is my pathologist, because can bill for more biopsies and make more money. Increased number of cores, we try to do that. We end up sometimes over detecting cancers that don't need to be treated, and the cost went up. So there's a problem with the existing system we've been doing for 25 years. What is the ideal thing? The ideal thing is to detect only potentially lethal prostate cancer, to avoid detecting or over-detecting clinically insignificant cancer, and to generate data that we can use, mapping of the prostate, so we know how to select the proper therapy, and we have to pay attention to the cost. And actually, I want to say one word on the cost. I don't know if it's important in Europe, but I think the savings, the upfront cost of having the machine in your office can be paid off for itself, because you're doing probably less biopsies and you're doing less pathology. So the cost of pathology and cost of biopsies savings justify the upfront cost of the machine. So this is what are the game-changing points here. Early detection of prostate cancer lesions have become progressively smaller lesions, we're finding, because we're doing early and more difficult to detect. The old-fashioned transstructal ultrasound has been around for 25 years, can miss a lot of those. Today is more common to encounter a lesion that may be focally treated with a focal therapy, and that also can help with the MRI to decide if you're going to go for focal therapy or not. So what do we do to improve our existing way of doing biopsy? Either we do, again, more cores, or should we have a better imaging and better guidance? So let's see what happens if you do more cores. So this has been published. If you do 6, or you do 12, or you do somewhere between 6 and 12, you're not increasing your incidence of picking up cancers. It's almost the same. This was published on the unilateral disease. The ultrasound started with the grayscale, and actually I was already in training when before here we had no ultrasound. We used to put our finger in the rectum and go through the perineum completely blind and do biopsies. And the senior guys in the audience can remember that. And then in the late 80s, early 90s, the grayscale ultrasound came in, and then that improved by having Doppler and having 3D imaging, and now we are dealing with the multi-parametric MRI, which is much more accurate, especially if you use rectal undercoil and other technique that can improve the imaging. So it was an evolving thing. The existing way of doing biopsies without MRI, we can miss easily 60% of the cases. And when you do 12-core biopsy, you are really sampling 0.04% of the prostate. That's what you are getting. You're making decisions based on 0.04% tissue. Ultrasound cannot visualize clinically significant tumors of a small size like the MRI can. So we're trying to target patients. We're getting less false negative with the new. When my radiologist tells me encircle the area, say this is where I think the cancer is a PIRADS 3 or PIRADS 4 or 5, usually we get cancer in that area, and we avoiding to detect any low-grade cancers. So it's more accurate, more sensitive, and I don't know if I agree with this 100%. Having a negative MRI doesn't mean you don't have cancer. We're still missing probably 25% on those patients. So where are we with all this? There's tons of literature published on MRI, ultrasound fusion biopsy, and Dr. Ahmed from England did a systematic review of all the literatures, and he started with 5,000 papers. Only 14 papers end up qualifying based on level 1 evidence. And he looked at those 14 papers. The conclusion in those 14 papers is fusion biopsy detects more clinically significant cancers compared with the standard technique, with a median of 33% more versus 23% using fewer cores. Still not the standard of care, because if you look at even those papers, they're not done the same way, not the same machines. Some are 1.5 Tesla, some are 3.5 Tesla, some with the rectal under coil, or without coil, with or without contrast. So it's still not standardized, so still not time to recommend it. Few major papers over the last few years came on this issue. This was from Dr. Pinto from NCI, one of the leaders in America in fusion biopsies. It looked at 1,000 patients. MRI biopsy diagnosed 30% more high-risk cancer patients than standard way, and also 17% less lower-risk patients. So MRI fusion is very accurate in showing you where the lesion is. That matches with your whole mount pathology. There's a great correlation between the location of the lesion. And that becomes very important when it comes to planning surgery, nerve-sparing surgery. If you know the cancer is here, you're going to probably not do nerve sparing on this side. So it helps the surgeons in deciding. Like I said, we have a problem with variations in the machines and the coils, the kind of software being used. And most important is the guy who's telling you where to go and biopsy. Not every radiologist knows how to read MRI for the prostate. So we have only 2 guys who knows how to read it in our town. It helps having a machine that has a 3.0. It helps sometimes in differentiating between prostatitis and prostate cancer. You can see here how the 3.0 shows much higher prostatitis. The rectal undercoil lecture is really tricky. We're not using it. Sometimes if you put it in the wrong place, can compress the prostate. You end up not seeing very well. If it's placed too low, it's a problem. Patients don't like it in the rectum, but it has its own problems, but it's an option. I think it increased the results if you do it right. Again, Dr. Pinto at the NCI looked at the anterior lesions in the prostate. These are in the anterior part. They are hard to get sometimes with the regular biopsies, and it's when you compare to regular truss versus MRI, you pick up more anterior cancers. Tumor size, again, is more sensitive when using MRI for tumors 5 millimeter or higher, and you catch more high-grade cancers if they are graded PIRADS 4 or 5. As far as the T3 disease, I looked at the literature, and there's all kind of papers. It goes from 28% to up to 75% sensitivity, so I'm not sure the exact role of MRI, and this is only from the radiology literature. Again, lesions can be seen clearly, and this is a paper was published on a case where actually it matched the pathology exactly, and the surgeon did only unilateral nerve sparing and did using the, this is if you have extension, that's what you see usually to the seminal vesicles. It can be seen much better than the regular ultrasound. So MRI can be done 3 ways. You can do it by looking at the MRI, put the films and look at them, and then go biopsy the patient with the ultrasound and try to go in the area where the MRI showed you. That's called cognitive MRI. And you have the actual fusion, the machine, the one we use is Euronav. And then in some centers, the patient is actually on the MRI machine, and the interventional radiologist can come in and biopsy the prostate. Very few centers are doing this in the US. It's mostly done by the urologist in the office. So this is the difference between looking at the MRI visually and between doing the fusion biopsy. You pick up obviously more cancers when you do the fusion. And this paper from England did not show a major difference between looking visually and between using MRI fusion biopsy, but there was some preference having the software in the machine slightly better, but not like the previous paper I showed you. So the fusion biopsy can be used on naive patients who first time, and most of my patients now are diagnosed with high PSA. I do MRI, and we send them, if they have a high lesions, PIRADS 3 or 4 or 5, we do the fusion. Sometimes we have problem with the insurance industry. They refuse to pay unless you already have one negative biopsy first, and then they will approve it. And then we have the patients who, based on the guidelines, you're supposed to biopsy them if they are on active surveillance on a regular basis. We're not seeing a major advantage of looking at MRI in patients who failed radiation therapy or focal therapy. I don't think you learn much from the MRI right now in those patients. It's stuck. There we go. Okay. So these are the how do you increase your sensitivity, and your negative predictive value goes up higher if you use only truss versus MRI alone versus biopsy with the MRI fusion. So we'd already discussed this. I'm trying to, am I okay on time? I'm okay on time? Okay, okay. So this is the difference between looking at the this came from the Dr. Marks here. They look at 105 prior negative patients who had negative biopsies, and they had fusion biopsy. 34% of them had prostate cancer. Conventional repeat biopsy detected the rate was less than 20% versus 54% when using the fusion biopsy. This is after having a negative biopsy first. So with primary negative biopsy, detection of Gleason 7 and higher, that's an advantage. Increased detection in both anterior and posterior tumors, like I showed you, especially the anterior ones. And random biopsy is still important, not just to do the area where the radiologist highlighted. We do still random biopsies because you can pick up cancers that way. And the frequency of in patients who had surveillance and then you end up rebiopsy them again, how many of them end up being moved up to a higher upstaged after doing the MRI fusion? And depends on who you read. Somewhere between 17 and 47% got upstaged and therefore moved into a more aggressive treatment. Fusion targeted biopsy contributes greatly to the cases with upgraded cancer, as I showed you earlier. Combined target and random biopsy is important because it will increase the chance of picking up cancers that can be seen. And current navigation system allowed to precisely sample the same cancer lesion over time. So you have somebody who are on surveillance, you can go back, you can pull all the old pictures, you can look at it, his PSA went up, we can rebiopsy the same area very accurately because the record is in the machine still. We still have problems with despite all this technology, we still are missing 32% of cases are being missed despite everything. How can we improve this? We are adding biomarkers like Dr. Brian Miles showed you. We have a lot of biomarkers to add. Adding biomarkers to your imaging and help you increase your sensitivity and your specificity of the biopsies. So multiparametric MRI is able to predict risk strata in 106 patients in this paper who underwent radical prostatectomy. The CCP, I think it's the Polaris test, was useful in some patients as a biomarker to add to it. We have some limitations, as I mentioned earlier. We don't have a standard way of reading the images. Sometimes you can show them different, radiologists can read them a little bit differently, so there's still no standards. There's a lack of uroradiologists in many towns. Most university hospitals may have somebody, but you are in private practice, we had to send our guys to special course to learn how to read MRIs. And of course, the cost issue, as I mentioned earlier. This is a paper looked at the costs, and in some places there was some savings, some places were no savings. It's all over the board. Depends how the methodology was done. As a conclusion, fusion biopsy benefit patients in all categories, naive or non-naive patients. It is becoming standard of care, although the main limitation should be addressed, the one I mentioned earlier, and we are still missing 20 to 30%. So are we at the prime time? Is MRI fusion studies MRI studies are becoming a bioimaging marker to the point where we can tell the patients, hey, you have a high PSA, you have an image that tells me you have prostate cancer, no need for a biopsy. Are we at that point? I don't think so. I think we are still missing some cancers, but maybe one day with improvement of technology, we can do that and avoid even biopsy. And that's the whole talk. Thank you very much for listening.
Thank you so much, Dr. Omar-Basher. Questions from the audience? Yes, sir.
Bashar, an excellent talk. A couple of questions. One of my problems with only depending on that is there's not a high level of concordance at this time among radiologists. Out of UCSF, I believe it was, at the last AUA, 30% at best agreed on the PIRADS of a lesion. So I'm uncomfortable depending entirely on that and ignoring the other parameters at hand, such as some of the genomic tests you've talked about, or even PSA percent-free. So I still use those and roll them into my decision whether to biopsy or not. But I'm curious, do you do a 12-core? Do you do a region of interest and 12-core? And if you do, why do the 12-core if you believe that much in the MRI?
Yeah. Anybody else? Other questions? No, under local block. We do a prostatic block.
Well, we know that you said that there was losing 25% of significant cancers, but that's comparing with traditional
60%.
A traditional transrectal biopsy.
Mm-hmm. Yes.
But the PROMISE study says, and it's probably the best paper about fusion biopsy, and they compared fusion biopsy with a template biopsy, and they lose 10% of significant.
With a template.
With a template.
Yeah.
So my question is, if 10% is not too much to lose patients, and if the template biopsy wouldn't be a little bit better than fusion biopsy?
I don't know anybody who's using template. Do you guys use template? Anybody use templates?
The problem with the PROMISE study is that, okay, it's not following the PIRADS designation, but it's comparing the use of MRI, fusion-guided biopsy, versus transrectal ultrasound versus template biopsy. And what it showed clearly is that if you are using MRI on your decision, it's improving your accuracy in terms of detecting which cancers are, in the definition they create, significant. So the trend is going for MRI and then as a decision procedure. The question here, as you said, is that, okay, we don't have enough radiologists to be experts. Perhaps here in some countries in Europe, like Netherlands, for example, they have more radiologists and they have a lot of expertise on multiparametric MRI. They are going on the in-bore biopsy on the MRI, which is, I believe, it's a method that is going to replace all the others, but it's not done by a urologist. It needs to be done by a radiologist, because with in-bore MRI-guided biopsy, you can sample all the gland, which even with transrectal ultrasound, sometimes it's not possible in some areas. Even you know if that area you should go and biopsy. So the trend is going to be the MRI in the decision process. The problem is that, okay, we are missing cancers, okay, but that is already occurring currently with the methodology that we are using. And we are currently missing more than the ones that we will lose using the new technology. But in addition is that how many of the lethal cancers are you going to miss with MRI? That is the question, because it's not cancers we want. We want to detect just the ones which are going to be lethal. And a lot of studies needs to be done. I think it's very important to standardize and to improve the knowledge behind multiparametric evaluation of the prostate. But I think the way forward is definitely using the MRI as the first approach for detecting.
Yeah, I am amazed at how many, the correlation between PIRADS. When he tells me it's PIRADS 4 or 5, and I biopsy that area, very, very few are false negative. Most of the time is right. False positive, I mean. Yeah.
Sorry, one last statement here.
You should continue the questions for the audience because Arnaldo is not here, and I'd rather have you there. And I
You
can
have to
join
come here.
But you have to sit here, Dr. Haas.
I just want to make a statement. Now, the future is not the MRI with fusion biopsy, is the fusion biopsy with Phi test. This is the present now, because with the Phi test we can exclude a lot of patients without significant disease. Prostate health index with
Yes.
+2 pro PSA.
Go
Okay.
ahead.
I'm going to make a comment. I mean, first of all, being in Europe and taking care of this problem, we organize courses for urologists in order to interpret MRI. This is the first step we have to do. Otherwise, you're going to end up in what you say. There's no correlation. In Europe, we have a bunch of people very good on MRI interpretation. And a lot of centers, and also my center in Modena, they do a lot of MRI, and now they are a correspondence between pathology and what they found out. So there is about 90% concordance on PIRADS 5 and 85 PIRADS 4. Question is, how can we be good in interpretation first? The second step is we must be good in getting the nodule. And so this is the urologist. Third is the pathologist. How can the pathologist be good in interpreting grade 4? And this is another issue. So we have 3 weak points we have to put together. So it's not so easy. And coming back to the way of doing fusion, not fusion, and so on, we, in our institution, we compared fusion versus cognitive. Cognitive is very simple because you have MRI, you have the nodule, and you go transrectally in the same nodule. And there is no much difference. It's 5% difference. So the issue is still there. We need more studies in order to be sure. This is our interpretation, our experience in Europe right now.
Yeah, thank you very much for those commentaries. Let me just put out a provocative thought for this audience. We are in the era of telemedicine that's growing by leaps and bounds in the United States. Insurance companies are almost demanding that we develop such technology. There are a lot of young people in the audience today. I think it's an opportunity to leverage a skill that only very few of us, really, as a scattered group, can identify 1 or 2 people that you can trust to read this technology. Perhaps this is an opportunity we can expand and have a call to action.
Can I make a comment about the MRI? For me, what would be important in an MRI to to use it with ultrasound to guide a biopsy is if they can detect microscopic disease. I'm not interested in a nodule. A nodule you can detect a half centimeter with your finger. I'm interested the capabilities of an MRI looking at microscopic disease that is less than a nodule. And someone here today talk about 2 millimeters or something.
But that's not what you want. You
For
want
sure.
to detect little
For
prostate
sure.
cancer.
And excuse me. Little cancers start as microscopic cancer.
Of course.
It's not just an evolution of size. I'm sorry. I'll give you a study that I just read because I'm presenting tomorrow focal therapy as part of cryosurgery, and this study is just being published. And what they did, they got about 400 patients that they did MRI, and they got PRADs in a number of them. A subgroup of those people decided to have radical prostatectomy. They then compared the findings of an MRI with what the pathologists found in the whole month section of radical prostatectomy. And that MRI still missed about 25% of the cases.
Of course.
See, that's my point. It's not important to me to have a nodule. We go back to no PSA, just rectal examination.
Yeah, you get it. But we are not still there, I think. Just knowing, Jelle Barents, came to our meetings so many times, and he is our chairman of these things, and I think he's the best in Europe and maybe in the world. And the question is right now, at least in my experience, I don't know your experience, it would be very helpful to know the experience of everybody. When you have a PIRADS 4 or 5 in the magnetic in MRI, and many times you feel a nodule, many times. You don't feel the nodule when it's in transitional zone or in the center of the gland. But if you make small studies, in the majority of cases, you feel something with your finger. But MRI is not able till now to give you what you mean. It means small, really small cancer, as you said before. However, if you have MRI, the negativity, if MRI is negative, you have 95% possibility not to have aggressive cancer. And my reply to you is, we need to know aggressive cancer. We don't need to know just region 3+3 cancer.
Exactly.
Comment.
Exactly. And, the studies from Dr. McNeil from Stanford, from autopsies, showed clearly that size matters in terms of detection and in terms of clinical aggressiveness of prostate cancer. He showed from the autopsy studies that a tumor needs to be more than 0.5 millimeters square cubic to be a significant cancer. So we are not going to detect, because that is totally impossible, cancers, minimal foci of cancer in a radical prostatectomy specimens by MRI. Because what we can do in a microscope, there is no machine that can achieve the same. So we need to think about MRI as the methodology that would be helpful for separating, sorting the tumors that needs to be treated, or let's say the tumors or areas that should be evaluated for diagnosis, and the cases which can be on a shelf and delayed in terms of procedures. If you are doing this, like the PROMISE study has shown, you spare a lot of money. It's impressive. There was a publication coming out on the European Urology about the cost of MRI and compared with template biopsies, and it's a huge increasing in SAVE. So I think, MRI is the way forward.
See, the studies that you're talking about, the nodules, this is a study from 20, 30 years ago. I personally don't believe that is true. Okay, I know the guy who published it. I don't believe that's true. Size matters, but the fact of the matter is that we have shown by molecular studies done by Makoska that microscopic tumors elsewhere inside of a radical prostatectomy specimen, microscopic tumors actually are quite often able to send metastases that have nothing to do with the dominant tumor. So size is something that it's over.
But how
okay?
can you detect
now,
them?
the second thing, let me finish
just
it.
ask you a question.
No, let me
Edson.
finish it first.
How can you detect them without MRI?
No,
Currently?
that was my question. My question is the following.
I'm sorry,
You
but-
talk about
but
rectal
really,
examination, and there is too many urologists here, and we think that we are very good, but I'll tell you a study that was done quite a few years ago by a fellow from Spain, who came as a fellow with us for 6 months, Javier Angulo, and we did a study in 60 consecutive patients that were going to have radical prostatectomy, in which myself as a senior urologist, Jim Monti as a senior urologist, our chief resident, and Javier Angulo did a rectal examination before a radical prostatectomy. The level of concordance among us was 30%. And the stage that we agreed the most was the T1C. Okay, so we think that we are very good, but we have to be careful.
Are there other questions that are out there? Give other folks in the back with burning questions for this panel or the audience.
Or comments.
Or comments.
Can we make a query? Who in the diagnosis uses +2 pro PSA and Phi test? Please raise the hand. Routinely. Okay.
Wow.
Well, there are
ahead.
enough bibliography now that states that we can discriminate a lot of patients and save them for biopsy and for MRI if the grade of Phi test is low or low to moderate.
Wait, hang on a second. That gentleman has a microphone. 1 second.
One question for the panel. Do you agree with the sentence, every patient who needs a biopsy of prostate must have a multiparameter MRI? Yes or no? At the beginning. On the beginning. Yes? Me too. Yes.
MRI is going to be not present, the future and more than the future. What I see is MRI, no biopsies, just treatment, focal treatment. I mean, this is going to be the future.
Right, so I'm going to butt in right there and take another poll for our audience. Who actually obtains the MRI of the prostate today prior to a biopsy? Raise your hand. Right, so it's still not the majority. There are substantial amounts of us, but can I just say that in the United States, one of the difficulties is getting insurance clearance. That's $5,000 plus. But this gentleman has a comment.
About this is a comment about your comment about the cognitive biopsy and fusion biopsy. The fusion biopsy, in my opinion, depends of the tool, because I don't believe put the CD and then make a artificial fusion. I believe in I believe in cognitive, or in my hospital recently I put a recent ultrasound that the patient first make the resonance and then put a marker. It's like a GPS, and then the patient go directly to the ultrasound, and the fusion is directly. Understand? It's like a cognitive. It's not like to put a CD and then try to put the dimension of the prostate and in the screen to make the fusion. I don't believe this. Okay?
This is your personal field. Okay.
Okay. According to Professor Calais, that's the last comment because we're going to have coffee break.
Right? Thank you very much.
Okay. Please. Okay. No, my comment is on focal. And I just reached when you say you're gonna speak about cryo. We doing focal therapy since many years. We were the first in Europe, first centers. And magnetic resonance is very important for deciding and for deciding the focal therapy. And first of them, we use template, but you know, many cores. And if you use MRI, I mean, cannot replace it. The problem is we need good radiologists to interpret, and we have to work on that. What EAU did is we organized courses, and in UK, Mark Emberton does, in Amsterdam, in Italy.
But you know, Mark Emberton has nine extras.
I know.
You know,
But
don't have this. It's in England, only has.
Can we
I think
continue
that's-
this discussion over coffee?
Yeah.
We finish it.
Last comment is from Dr. Miles. Where are you, Dr. Miles?
I was just going to say, don't forget, getting a UroNav machine costs over $300,000, so that most urologists who would love to do the biopsies, MRI guided, can't afford it because most biopsies by far are done in private offices.
Thank you very much.